Himantha, good evening.
Sorry, yes, I hope you can hear me.
Yes. Saranga? The moderator will start. We can start because we have now.
Right, that's okay. Yes, I'll wait.
Um,
Hello.
Saranga, you
Yes,
start. No? Yeah, we have enough audience right now. They will join.
Dr. Aziz, I have joined.
Yeah, you can start. I can introduce our speaker and then we can go on.
Yes, good evening, all of you, and welcome to another session of elderly care medicine. And today's topic is joint disease in the elderly. A lecture discussion based on management issues in general practice, organized by the Elderly Care Committee of College of General Practice of Sri Lanka. And today's speaker is Dr. Himantha Atukorale, Edinburgh, of American College of Rheumatology, co-convenor of Asia Pacific League of Association of Rheumatology-Young Rheumatologists, consultant in rheumatology and rehabilitation, attached to Radicular, and also so is a former student of Royal College, and so his father is actually a former cardiologist, Dr. Atukorale. It's our pleasure to invite you to this session, sir.
thank you. Thank you. Dr. Sarang. What I'll do is, first of all, I have to thank the College of General Practitioners of Sri Lanka for inviting me to do this lecture, and Dr. Sarang Talagala for being the moderator, and of course, Dr. Asita Tanipuliarachi, my classmate and my very good friend, for inviting me to do this. So, and I consider this a privilege because uh, GPs, as like name them, are the unsung heroes who do loads of like tasks in enhancing healthcare, especially in the elderly. So I thought of doing a certain this topic because it's so much relevant. So shall I start the presentation? Is it all right if I start, Dr. Saranga?
Yes, sir, you can start, sir.
Yes. So I'll share the screen. Um, so Right. I hope you can see the screen, and now I will try to make this presentation I will present in an unorthodox, offbeat way so that you won't fall asleep, and I will simplify this to the best of my ability so that it's very well comprehended. So now a very brief introduction. And now the WHO states that the number of people aged 60 years and older were 1 billion in 2019 and expected to exceed 2.1 billion by 2050. And it also states that older people commonly suffer from things like hearing loss, cataracts, arthritis, COPD, diabetes, and dementia. The additional years spent by geriatric people provide them with opportunities to contribute to the society and pursue new jobs, but the limiting factor for this is their health. And I'll just briefly show a population pyramid. Actually, this is a population pyramid, two pyramids. One to your left side is what China had back in 2002, and one to your right side, if we time travel 20 years ahead, you'll witness this population pyramid on the right. So, left side, the population pyramid looks like a proper pyramid with a wide base and a pointed top. Whereas the right side doesn't look as a properly, because there is this narrowing of a segment of the population which is between the ages of 20 to 55, right? So there's this narrowing which will happen eventually even in Sri Lanka, and you can see an expansion of people age 55 and above in 20 years time, this is what awaits us. So we have to prepare beforehand to encounter these problems that are associated with the elderly. So now I will only cover two main ailments in joint disease, because it is a vast topic and I won't be able to cover everything. The first topic I intend to cover is osteoarthritis of the knees and knee pain. And the second is I will cover about back pain. Right now, if we speak about the etiology, now I was told not to go into a lot of pathophysiology details, which I won't. Now, if we speak about the etiology of osteoarthritis in the elderly, it's mainly age related, and there's this reduction in cartilage proteoglycans, and also OA can happen when you excessively load a healthy joint, as what happens in obese people, or if a normal loaded joint is traumatized, right? So if you load a excessive, you load a healthy joint with an excessive load, or if a normal loaded dose like joint is traumatized, and there is this family history as well. And so the symptoms are usually aching types of pain, initially relieved by rest, and reduced range of movements. Mainly, the range of movement is reduced because of restriction, because of pain. And there's this crepitus of the affected joints, and there's this thing called gelling phenomenon which can happen. This is stiffness which occurs during rest, and there's also morning stiffness of the joints which can last for less than 30 minutes, usually less than 30 minutes. Later on, when it worsens, the pain does not resolve by resting. So these are the main symptoms of osteoarthritis of the knees, and it applies to the other joints as well, all the other weight-bearing joints, even the ankle osteoarthritis or osteoarthritis of the hips presents in a similar manner. And the signs, now joints will have bony swellings. Now, there are three types of swellings which happens in the joints in rheumatology. One is where you have an effusion within and the joint swells up. The second type of swelling is a soft tissue swelling, which is also known as synovitis, where the covering layers of the joint expand, and this produces a swelling. And the third type of swelling is seen in joints is a bony swelling because of calcium deposits, which we call osteophytes. Now, joints may have osteophytes in osteoarthritis of the elderly, and there's no overlying erythema of the skin or warmth. They might have an effusion within. Usually, it's not seen in many, but might be seen in a few. And there's this muscle atrophy, which we tend to ignore. Now, if you look at this photograph, you can see that the quadriceps muscle is wasted. There are several things, but disuse atrophy or lack of use of the muscles because of the pain, patient doesn't mobilize themselves, and this causes disuse atrophy. So muscle atrophy is also a sign in osteoarthritis in the elderly. If you focus onto the hands, most of the affected the joints are confined to the distal or proximal interphalangeal joints, and Herbert's nodes, which are bony expansions of the distal interphalangeal joints, are more seen in women, elderly women, and inflammatory changes seen in inflammatory arthritis. These are typically absent. If we go to investigations, there's no specific investigation and no biomarker available to definitely diagnose osteoarthritis. Now, this is a drawback. ESR is usually not elevated, but it might be slightly elevated if there's an overlapping inflammation. The synovial fluid, aspiration and analyzing synovial fluid is usually inconclusive. Then the investigation of choice is usually a plain X-ray when it comes to radiology. Now, MRI and CT scans they play no established role in initial investigations in osteoarthritis. But MRI is useful, especially to an orthopedic surgeon when it comes to replacing the joint. Now, what you see on the left side, is a normal knee with a normal gap in between the bones, femur, and the tibia. But what you see on the right, the figure number 2 shows narrowing of the joint space because of lack of cartilage and these bony deposits. What happens here is again the body tries unsuccessfully tries to attempts to repair the narrowed down cartilage layer by depositing calcium on the adjacent uh, areas closer to the knee joint. But it's an unsuccessful attempt to repair because it doesn't serve a purpose, and there's the joint space narrowing and adjacent bony spurs, which we call osteophytes. Now, management. Now, this is please don't worry about this. I won't go into details about this, but I just want to highlight certain things in this very, very useful diagram, which was published in Nature Reviews in a very it's a very useful article. Now, there are things called core treatments, which are appropriate for all individuals, and there are other treatments based on certain patient categories. Now, if we go to core treatments appropriate for all individuals, elderly people who have osteoarthritis, these are land-based exercises, weight management, strength training, and I will go into details of this. So first, I will speak about land-based exercises. Now, these are usually exercises which are done inside a gymnasium or inside a physiotherapy lab. Or within their own homes, patient can be taught to do this. Now, there are several categories of land-based exercises as well: static stretching exercises and isometric strengthening and isotonic strengthening. So these are very useful to bring down pain, and these are non-pharmacological methods of countering pain. And some of the exercises that are frequently used worldwide which can easily be practiced by elderly are shown in this diagram. I won't again go into details, but these are easily found in any reputed website. Um, and weight management also plays a key role. If a patient is found to be overweight, and if you like encourage them to lose about 10% of their body weight, usually the joint pain is nearly cut down by 40 to 50%. And because loss of even 10 pounds removes about 30 to 40 pounds of pressure off your knees. Then hydrotherapy, which is water-based exercise, which is proven to be it's proven to be superior than land-based exercises, and various protocols are there. Now you might wonder how we do hydrotherapy in Sri Lanka. Now it can be done in a simple swimming pool, as well as now when I was working in Anuradhapura, I used to encourage them to do this in when they submerge themselves into tanks. Whereas I encourage them to do these simple hydrotherapy exercises. Now, I'll show some very short video clip of three very simple aquatic exercises which you can do to bring down pain of hip osteoarthritis as well as knee osteoarthritis. So these are very simple lunge-like exercises, certain exercises which promote circumduction of the hip, and these can be done, and these are proven to be more effective than land-based exercise. So we can encourage our patients to do some of these things. Then walking cane use is also a non-pharmacological method of bringing down OA related pain. So now walking cane, when it comes to walking canes, there are three adjustments which we have to concentrate upon: a correct height, the correct side, and correct coordination. So this is how you adjust the correct height. In any walking cane, the walking cane handle should go right across the wrist joint level. So that is the correct height. It shouldn't be too short or it shouldn't be too long. And so these are some of the images that I portray on a daily basis at my clinic, where we encourage them to use walking canes, which is a very simple but a proven remedy for osteoarthritis, a non-pharmacological method. And then walking cane should be used on the correct side. Now, if you look at this diagram, the affected lower limb, which has osteoarthritis of the knees or let's say the hips, is on the left side, which is like shaded. The person holds the walking cane on the opposite side, the good side, and the affected leg as well as the walking cane should move together, whereas the intact or the less severe OA leg should move independently of the other two. So this is the correct way. So even when the patient is climbing stairs, they can use this correct method by using the affected lower limb as well as the walking cane together with the healthy leg moving independently. And this is a proven remedy which works by offloading the affected leg and then bringing down the pressure mounted on the tiny narrowed down knee joint. And medical management. Now, paracetamol can be used for mild to moderate osteoarthritis pain, and then we can gradually increase the PCM dose. And the correct thing is to then add things like topical NSAIDs. There are various topical NSAIDs, and there's no proven this what you call a definite topical NSAIDs that work for everyone. So it's through trial and error process that we try out certain topical NSAIDs, and if failing which we move on to another. Oral NSAIDs can be tried later on, and if the pain is highly resistant to oral NSAIDs, we could try things like tramadol. But we have to be wary of dependence. Now, speaking about heart disease, NSAIDs and osteoarthritis, now there's this research which has shown that two-thirds of the increased cardiovascular risk associated with osteoarthritis in the elderly is linked to the use of non-steroid anti-inflammatory drugs. So, no drug is safe. Naproxen at lower doses is relatively safer than other NSAIDs when it comes to heart disease. But diclofenac was the drug that was found to be most effective for the treatment and pain of osteoarthritis. And it's superior to other NSAIDs like ibuprofen, naproxen, and celecoxib. Always we have to check the renal functions prior to and after initiating NSAIDs. And remember the statement that no NSAIDs is safe, but we can practice at a lower dose, and naproxen is relatively safe, not absolutely, but relatively safer than other NSAIDs when it comes to heart disease. Then this drug called duloxetine is also highlighted in that previously stated article. Now you might wonder why we prescribe duloxetine or antidepressants for knee osteoarthritis in the elderly. Now, chronic spontaneous pain, in contrast to acute pain, is perceived at limbic regions in the brain, which holds a lot of emotion. Now, limbic regions is where we comprehend emotions. So, simply, chronic spontaneous pain has a huge emotional component for which duloxetine was found to be very useful. So that's why we prescribe duloxetine in relatively small doses. But again, be careful about drowsiness and also instability and falls in the elderly when prescribing this drug. Injecting the knees, now we do use injections, but if these are given continuously, let's say every 3 months for over 2 years, they have found that this results in a greater cartilage volume loss and no significant difference in knee pain. So repetitive knee injections are not encouraged, but we do inject to aspirate as well as inject drugs such as depot preparations of methylprednisolone or triamcinolone. Now, I will move on to back pain in the elderly. Now, there are several types of back pain that might cause very severe symptoms, out of which mechanical back pain and radiculopathy are the commonest. I won't go into details on how to resolve osteoporotic compression fractures and inflammatory back pain, which is also sometimes seen in elderly, and also neoplastic and infection cause I might have to avoid because of time constraints. Now, mechanical back pain in the elderly could be due to three main reasons. It could be due to degenerated discs. It could be due to facet joint problems. I will explain this. And it could be due to damaged soft tissue such as muscle sprains or tears. Degenerated discs. Now, what you see on the right side, the image shows healthy discs and degenerated discs. So what happens here is when the discs undergo degeneration, the vertebral bodies come in close proximation to each other, and when they approximate, there are again things like osteophytes and calcium deposition in adjacent areas adjacent to the joint space. And this can cause pain. And now facet joints, we always forget that in between vertebrae there are three joints. The key joint is the intervertebral joint, but there are two facet joints in between any two vertebrae. Now, role of the facet joints is usually to limit torsion and resist forward displacement of the vertebrae. But what happens if the discs undergo degeneration? Then the facet joints also take over weight-bearing functions. This shouldn't happen, but this happens in the elderly, and then we see facet joint degeneration. Now, osteophytes formed around the facet joints because of these calcium deposits can go and pinch a nerve or two, and this can cause nerve-related pain, which we call radiculopathy. Facet joints also can cause, after wear and tear, it can independently cause joint pain. So there are two facet joint can cause both axial back pain as well as radicular pain. Mechanical back pain. Now, most elderly with acute back pain recover within 6 weeks if it's acute back pain. Some experience persistent or recurrent back pain that can last for several months to years. This is the natural cause. Now, radiculopathy is, as I stated earlier, could be due to mainly three reasons. Now, facet joints can cause a pinching of these nerves. A bulging disc can cause nerve radiculopathy or nerve-related pain. A ruptured disc can also cause this. So there are various reasons for radiculopathy in the elderly. This can also cause back pain, and the natural cause is most of the elderly experience significant improvement within 6 to 12 weeks after starting conservative treatment. Conservative treatment involves physical therapy, pain management using drugs like NSAIDs, and exercise therapy. A small percentage, a very small percentage, may require surgical intervention. And radiologically, the good news is two-thirds of the herniated lumbar discs undergo significant resorption within 1 year. So it's good news. So it doesn't last forever. Now, this is, I won't again go into details, but I just want to highlight certain things like now inflammatory back pain, how it differs from mechanical back pain. Now, inflammatory back pain is seen usually in people who are less than 40 years of age. Now, mechanical back pain can be seen at any age. And the biggest differences are inflammatory markers such as ESR are commonly elevated in inflammatory back pain, and in mechanical back pain, usually these are normal. And morning stiffness is very mid and short-lived in mechanical back pain in elderly, whereas in inflammatory back pain, it can persist for more than 30 to 45 minutes. Exercise improves inflammatory back pain, whereas exercise might worsen mechanical back pain. Right. History and examination. Now, if it's sudden onset back pain, it should be usually discogenic low back pain, disc-related back pain. If it happens with a delay after a certain injury, after several days of injury, it could be paraspinal muscle tears or ligamental strains or facet joint arthritis. Discogenic low back pain usually occurs within minutes. Usually, a person is less than 45 years. But having said so, we have commonly encountered patients who are very old as well. The onset is sudden, and it's worsened by activities that load the spine, and it's better when the patient sleeps. So, whenever you load the spine by even standing, it worsens discogenic low back pain, and the patient recalls instances when they lie down, it becomes better. Paraspinal muscle or ligamental strain, it happens within days of an injury. It usually happens 1 to 2 days after the incident. Most of the elderly patients can't recall the initial incident. It localized to the lumbosacral region, and there's this hypomobility of the affected region because of severe muscle spasm. Facet joint causing low back pain, it's a gradually worsening pain which happens within months or years, and it's usually seen in people who are over 65 years. It's again worse when standing, and it gets better when the patient is seated, leaning towards the front, because facet joints are offloaded when you lean over to the front. Or when the patient is recumbent, when the patient is sleeping, the facet joint arthritis related pain disappears. Remember that it's a slow onset pain. It's not a sudden onset pain. Now, radicular pain can be sudden or insidious, and usually it shows this dermatomal pattern because it compresses a nerve. It should follow a dermatomal pattern. So the patients might describe that the pain radiates to the umbilicus, or pain might cause something similar to sciatica symptoms, where the pain goes within the buttock to the backside of the leg towards the calf muscle. And so some patients unnecessarily undergo loads of radiological investigations such as ultrasound scan just to figure out whether something is wrong within the abdomen, whereas the actual pathology lies very superficially. The radicular pain is worsened by anything that increases the intrathoracic or intra-abdominal pressure, right? So cough, sneezing, or prolonged sitting can increase radicular pain. The diagnosis now, early imaging in back pain has not been shown to improve outcomes in patients. So now this very useful chart describes how we should do immediate imaging. Now, immediate imaging is only indicated if there are major risk factors for cancer, or if there are things like suspected spinal infection, signs of Coda equina syndrome, or severe neurological deficits. We should defer imaging until the initial treatment in other cases. So it's very simple. If there are major risk factors for cancer, or if there are infections, if there are things like Coda equina syndrome or neurological deficits, only that we go for immediate imaging. But whereas we can delay these till we treat the patient for at least a few days. Now, it's very important to identify the facet joints in a plain X-ray. That's why I put these two diagrams. Now, on your left side, you will see facet joints clearly seen as slit-like radiolucent areas, like from top to bottom. Now, these are seen on the arrow. You can see them at the areas where arrows are pointed. Now, in severe facet joint arthritis, these become radio opaque with like a lot of calcification. The facet joints, if the facet joints have undergone arthritis, degenerative changes. Now, electrodiagnostics, nerve conduction studies are useful to confirm the existence as well as the nerve root level. Uh, so sometimes we do nerve conduction studies, and these are useful in certain instances. Now, pharmacological management in back pain involves these types of drugs: NSAIDs, muscle relaxants, opioids, antidepressants, and anticonvulsants. I'll just go through these. Um, so, what should we use as first line? Now, NSAIDs are the preferred drug of choice, and ibuprofen and naproxen are widely used in back pain in the elderly. Now, these are worldwide statistics, and so what is frequently used are NSAIDs, followed by paracetamol, and then comes muscle relaxants, antidepressants, and opioids. Now, muscle relaxants, drugs such as tizanidine can be used. The evidence for their long-term efficacy is limited, and these are preferred for relieving acute rather than chronic back pain. Antidepressants, drugs such as amitriptyline and nortriptyline, are two tricyclic antidepressants that can be used for reducing back pain, and even duloxetine and venlafaxine are useful uh, and are found to be effective in managing back pain. Opioids are potent pain relievers, may be useful for severe acute pain, but long-term use for chronic pain is highly controversial. Anticonvulsants, again, their evidence for long-term efficacy, drugs such as gabapentin, pregabalin, is limited, and they can cause massive number of side effects In the elderly, now things like drowsiness, dizziness, falls are quite common in patients, elderly patients who are on anticonvulsants. Now, there are various modalities of physical therapy, exercise, manual therapy, electrical stimulation. And so, exercise therapy is a proven method of bringing down pain and improving function. There are various exercise regimes that can be used in the elderly. Now, there's this good website called versusarthritis.org, which is a very reputed website where you can find all these exercise the types that can be used by any person of patient of any age group. I won't go again into details. Now, electrical stimulation is also a non-pharmacological method of bringing down pain. The effects are short-lived. What we have here in Sri Lanka is transcutaneous electronic nerve stimulation, which we call TENS, which uses low frequency electrical pulses. These can be also bought by the patient, and they can be applied repetitively or even on a daily basis by the patient. But the effects are short-lived. Now, there are other treatment modalities such as heat therapy and also traction, which are mainly used by physiotherapists to improve or bring down the pain. Now, I just want to highlight some certain things before I end up. Now, if you compare three rheumatology patients, one like a child of 10 years, a person of 26 years, and a 70-year-old person, patient. Now, there's this established specialty called pediatric rheumatology in other countries. So we do have a subspecialty, and there are even transitional rheumatology clinics for adolescents, even in Sri Lanka. But is it justified to use the same management approach for a 26-year-old person as well as a 72-year-old person? So this is exactly what happens here in Sri Lanka, where we do not treat them based on their age. So there is this like established specialty called geriatric medicine in Sri Lanka, whereas where we do not have geriatric rheumatology even in developed countries. I am in this process of like introducing this specialty, not just within Sri Lanka, but in Asia Pacific, certain Asia Pacific countries, because if we do not do this right now, we are going to encounter huge problems. Now, so, what does a geriatric rheumatology patient whom you might encounter in your practice actually require? They require pain-free, comfortable, and functionally independent life. So, do we cater to the above requirements? Usually, even in established rheumatology clinics, we do not cater to these requirements. I just want you to highlight certain small certain things that we might have to analyze in future in even in GP practice uh, when it comes to joint disease in the elderly. Now, functional capacity, there are tests such as senior fitness tests to assess how capable they are, how functional they are, the elderly patients. But we do not have an established protocol in Sri Lanka to address these things, such as functional capacity. Now, this is a standard method of assessing functional capacity called senior fitness test, where we assess certain portions of the body, the lower body, the upper body strength, and also endurance, the flexibility. These can be done by you as well in future when you encounter patients, elderly patients with joint disease. Now, frailty is another interesting thing. And so there are established methods of assessing frailty. And so these are some of the questionnaires that are used. Edmonton Frail Scale is a famous scale that we use to assess frailty. Now, age, age is age and being old and being frail are two different things. So some people you might encounter who are quite old, 80-year-olds who look like Hollywood actors, but where sometimes we might also encounter patients who are just 55 or 60 years of age who really look very old. So this is where frailty comes and takes over the like health of some patients. So then sarcopenia is another theme, another thing that we fail to assess in patients. Now, sarcopenia is loss of muscle mass. Now, there are again various clinic-based tests that are available to do this. So, this is one method of assessing sarcopenia. Uh, Now, a 65-year-old uh, person has only one half of the muscle mass that that person had when they were there. They just lose more than 50% of the muscle mass in comparison to what they had at the age of 20 years. So, sarcopenia is one thing that we again should address or assess in patients. Now, falls. Now, there are various methods to assess the risk of falls. I also, I'm grateful if you could just assess these as well, because these are also like burning problems that some of the elderly patients might encounter. Then memory issues, as you know, you might also do these, but there are various scales to assess memory as well in elderly, and also independence. In there are various indices of like categorizing independence. CATS index is a famous index. So these also matter a lot in when it comes to geriatric rheumatology or elderly joint disease in the elderly. So these are cost-effective tools, and these by assessing these, like it enhances doctor-patient bond and it saves money as well. There are certain disadvantages as well because all these are time-consuming. So, will there be a dawn of a new era where perforated peptic ulcers, acid perforated peptic ulcers are a thing of the past thanks to PPIs, the prostate surgery and BPH is obsolete thanks to finasteride, falls and related fractures? Will it become a thing of the past because of geriatric rheumatology? This is a question that remains unanswered. And there are certain other things that I just want you to focus whenever you encounter an elderly patient. Now the font size, the clarity, and assessing memory loss before prescribing might be very useful. And simplifying the dosage once daily regime or something which suits the patient might enhance the patient compliance. So I just want to highlight this as well. And we did several surveys. We did a survey at a private rheumatology clinic among all the patients, and a lot of patients, more than 90%, agreed on a necessity for a separate geriatric rheumatology service. So this is again a burning necessity, and so they had lot of issues with when it came to related drug disease related advice, drug side effects, meal plans, weight management, lot of unanswered questions. And we also did an audit on polypharmacy, which was again published. And most of the patients were on 8 different types of medication, out of which 6 were meant for rheumatological ailments. And they had perceived this improvement in health with multiple medications. And when questioned how often they miss taking medications, now nearly 15% admitted that they missed taking their usual meds on a weekly basis. And 25%, one-fourth of our study population had mixed up taking medications. So this is again a serious issue. And 88% expressed the need for bystander for their rheumatology consultation, and 83% wanted someone to talk to about their symptoms. So I should admit that we don't provide all these services at a standard rheumatology clinic for the elderly. And 42% felt depressed because of joint pain because it's 24/7 and goes on for years. And 17% felt that they need to receive treatment for their depression. Now, as a concluding note, I would like to highlight that joint disease in the elderly will be a common encounter at the GP's practice, and low back pain and lower limb joint pain are frequently encountered. simplifying prescriptions might improve patient compliance, and checking for polypharmacy and side effects of medication is a must, and non-pharmacological management strategies might improve stability and prevent falls in the elderly. So this concludes my the short presentation. Thank you very much. And if you have any questions, I'm more than happy to answer.
Himantha, thank you very much for a great lecture.
Yes.
Enjoyed it a lot. And you talked about very good points that we certainly missed. Can you answer my question? It's about GPs, general
Yes.
practice, maybe because we spend a lot of time in our private practice in the morning and in the evening. Sometimes they can have back pains, GPs.
Yes.
Do you encounter any general practitioners coming to you with certain
Yes, sir. This is a common encounter, not just general practitioner, but a lot of, I think, medical officers who do like long shifts, even in ICUs, even in theaters. And I think one of the main reasons is lack of exercise. So, most of them might have done sports during their teenage or childhood days, but they have given up these things because of their like huge commitments as a medical professional. So we do encounter, yes, back pain in most of our doctors, and it's a very common encounter, not just doctors but even medical students. When I used to work in uh, Rajaraja University, we encountered a lot of medical students having chronic, what we call non-specific back pain. So none of these GPs that I encountered were in their geriatric age group. By the way, they were uh, they were they were young
young?
medical officers. Yes,
Thank you. Thank you.
so I can see some hands.
Excuse me, sir. Uh,
Yes.
if we decided to give steroid injection for osteoarthritis knee, what is the best
Yes.
time? It is early in the disease or late in the disease? So what's the
Uh, uh,
effectiveness if it is in the late?
Yes, any joint. Thank you very much for the question. Now, we can give injections even in the early phases of osteoarthritis or any type of arthritis, and aspiration and injection can relieve a lot of symptoms, as well as it's very useful. It's a very useful method of bringing down the types of drugs that the patient are on, rather than putting them on loads of drugs for several weeks or months. It's a quick way of relieving, but the issue is repetitive injections might be of great concern when it comes to elderly, because as I told you earlier, the cartilage thinning out is clearly observed when repetitive injections are given to the same joint, especially using depot preparations of methylprednisolone. So, even in the early course of disease, we can just give steroid injections to any joint that is like swollen and has a bit of inflammatory arthritis features, not just osteoarthritis, but a bit of inflammatory arthritis. They do respond well. Yes.
So I'm Dr.
Okay,
Faril. I have three questions.
Yes.
One is related to glucosamine and chondroitin sulfate. I think there is no
Good.
evidence for
No,
using
no
that,
evidence.
but we
No
are
evidence.
getting a lot of prescription from our GP side.
Yes.
I think there is no evidence. I think the other second
Yes.
question is the PRP treatment, the platelet-rich plasma. It is widely practiced in I think Western world, and now it is slowly introduced to Sri Lanka as well.
Yes.
So, what is the recommendation for PRP in osteoarthritis?
Yes, now its PRP was initially introduced to counter sports injuries, and again, it's not proven to be effective in relieving well-established osteoarthritis. So, most of the rheumatologists do not practice platelet-rich plasma injections. Since it is known to have a placebo effect similar to glucosamine, because you invest in an expensive product. Some feel that it's proven to have a placebo effect, but that is also short life. So it's not useful. That's the ultimate conclusion.
So one more question related to, again, osteoarthritis. I have seen even specialists prescribed disease-modifying drugs for
Yes.
osteoarthritis. Is there any place for disease-modifying drugs for
Yes,
osteoarthritis?
yes. So there is this category of osteoarthritis which we face. It's called inflammatory osteoarthritis, where there is an overlap of things. Now you have the wear and tear injury or wear and tear of a certain joint like the knee joint, and there are clear-cut signs of inflammation with recurrent effusions as well as inflammatory arthritis, where we use disease-modifying drugs. The most commonly prescribed disease-modifying drug is hydroxychloroquine. We have to carefully check see for signs of inflammation before prescribing. If not, there's no place in just blindly prescribing drugs such as hydroxychloroquine.
The last question is related to hydrotherapy. So in our setting, we don't have a swimming pool and all those things.
Yes.
Any suggestion that we can give, as for our patient to do hydrotherapy?
Yes, when I was working in North Central Province, I asked him to go to the nearest tank. You have lots of tanks in North Central Province, then wherever. So some of them did actually. Some of them, because they were very good swimmers. So now usually hydrotherapy pools are slightly these have warm water. So and it's automatically they're available in places where you have large tanks. Uh, there is this issue where we do not have access to proper hydrotherapy. Actually, the correct method is for the physiotherapist to also submerge in the pool and instruct the patient. So this doesn't happen. It's very difficult to implement in Sri Lanka. So I do admit that there's an issue. But if done properly, this is even simply wading through a swimming pool is useful because it's some sort of resistant training for the muscles. So yes, there is issue because we do not have access, so there's no solution for that right now.
Thank you very much.
Yes. So I have some questions also which I can see now. PRP I have answered. Steroid injections also I have answered. Now, what is the total recommendation for total knee replacement or replacement for people who are above 70 years of age? It is done for patients who are even in their 80s. If they now the biggest challenge that we face is if a person remains immobile because of let's say knee osteoarthritis for several years, let's say for a decade, there are significant muscle wasting. So ideally, we have to assess the muscle strength and as well as the muscle bulk before uh, going ahead with a knee replacement surgery. So that's a must. In a person who has never mobilized properly, who was wheelchair bound for let's say 5-6 years, uh, we have to be very careful before going ahead with a knee joint replacement. Even if the joint is replaced, the patient might not be able to mobilize the affected joint because of muscle wasting. So the key thing that comes to my mind instantly when I read this question is we have to assess the ability for the patient to properly mobilize the knee. The age is no barrier, but the muscle strength and the muscle bulk matters a lot. So that's the thing. And there are other contraindications as well for surgery, like they say severe ischemic heart disease and any problems to do with anesthesia. We have to be wary of those things as well. But usually, age is not a limiting factor for total knee replacement. Yeah, so is there any place for fish oil is another question that has been asked. Again, it's not proven. Omega-3 and those stuff. Though there's an issue also with fish oil, which I have seen. I haven't carried out any research about fish oil in our population, but we have seen like people have some of them are on these vitamin even fish oil omega-3 preparations for years, and that might cause obesity as well because some of them are taking more than 3-4 tablets per day. These are concentrated bits and pieces of oil, so might go because in an inactive person it might not serve any purpose. So that's my conclusion, and it doesn't cure osteoarthritis. No, it doesn't. And can we treat elderly with vitamin D3? Yes, vitamin D3. Yes, and first of all, I think it's best to advise them to modify their diet, and then we can prescribe vitamin D3. Please note that the best method to obtain vitamin D3 might be I wrote an article about this to Daily Mirror as well several years ago. The sunshine pill, as I call it, is the best. So the best time to bathe in sunlight is between 10 a.m. and 3 p.m. when the ultraviolet B rays are at its highest. So UVB rays are at its highest between 10 a.m. and 3 p.m. Not the conventional thing that we were taught early morning or late in the evening, but between 10 and 3 p.m. And at least 30 minutes of sunlight per day for 30 minutes you have to bathe in sunlight. And vitamin D3, yes, it can bring down certain symptoms of osteomalacia, which is just two things: bone pain and muscle weakness. So it can improve that. Might not have a place in osteoarthritis, but it's useful, yes. And there's this other question where they have do we always need to take an x-ray to diagnose? No, no. It's not an absolute must. Even through simple palpation, if you feel that the joint is deformed, and if you see bow legs or even knock knees in an elderly with osteophyte rim, which is felt, it's diagnostic of osteoarthritis, so, and you can just directly go ahead with treatment. Then I think these are the questions.
And I think, yeah,
Any other questions that I am feel free to ask,
Excuse me,
please.
sir.
Yes.
Between two steroid, we are having the triamcinolone and methylprednisolone. What is more effective in for joint?
uh, Methylprednisolone is the drug that is tried worldwide. It's a commonest use. Triamcinolone is also used, but we prefer to use methylprednisolone, which works best. Yes.
Okay, sir. Thank you.
are there any questions? So,
Himantha, can you also tell, as a
Yes.
rheumatologist, what are the main errors or one or two errors that you see in clinical practice from the general practice side? What we
Actually,
may
I see you as unsung heroes actually, because you carry a very huge burden. Like, you just prevent lots of OPD patients for us, and even admissions. And you haven't received the GPs in Sri Lanka do not receive the due credit that you should receive through any government or any other institution. So I'm really upset about that. So now mistakes, Asita, even consultants make mistakes. So I do not like to point out individual mistakes, because and updates such as these might even prevent lots of mistakes. But I think I shouldn't be answering that. So, but I haven't encountered any grave errors in any because they have, some of them have done marvelous jobs in preventing, bringing down pain, and enhancing mobilization in lot of patients, and they are really happy with their GPs. And so, I am always praising the GPs for what they do, but I'm sad that they are being not recognized for their services. If all GPs stop practice for even, let's say, 1 week, the government sector would collapse within 1 day, because our OPDs cannot cope up with such a large number of patients. So it's quite obvious, and despite this obvious fact, it's not being properly appreciated. That's the sadness that I have. That's my answer to your question.
thank you, thank you very much for appreciating us.
So I have two last. I think there are two. So is there any place for oral methylprednisolone? No, in osteoarthritis or even in elderly joint disease, oral methylprednisolone might not, because of the side effects, and so we usually it's not, unless there are clear-cut inflammatory arthritis features, for which we use methylprednisolone as bridging therapy. Bridging therapy is where we cover a small gap till the disease-modifying drugs act. We just send this drug to quickly bring down inflammation, not in standard osteoarthritis management, no. And also polycalciferol. So I think I spoke about vitamin D. So vitamin D3 is the thing that we usually prescribe. Uh, um, 1-alpha is not a proper. If patients are having intact renal functions, there's no point in just prescribing 1-alpha. So vitamin D3, the metabolite that is being produced by the liver, it's the proper drug that should be given. So local applications, any application is now strangely the American uh, Orthopedic Society has given they recommend capsaicin ointment, which is basically capsicum ointment for osteoarthritis of the knees. So because it just produces a burning sensation and just brings down, or it just allows our body to produce our own endorphins, as well as it just prevents the brain from concentrating on this pain that's coming from deep within the joint, because the brain just concentrates on the superficial pain, so it just confuses us into thinking that the burning sensation is more than the pain from deep within. So there's no topical. So there are various types which I have mentioned in my lecture, or proven uh, ointment, diclofenac ointments, and the methyl salicylate. So just through trial and error that we come to a conclusion. How long the NSAIDs can be continued in osteoarthritis? There's no time limit, and there's no specific safety of prescribing this drug called Solindac, which sometimes some of us think is renal safe, but Solindac can also cause renal failure. So any NSAID can cause renal failure. So there's no, you can prescribe it even for years, but you have to occasionally assess for things like tubulointerstitial nephritis, or any rise in serum creatinine. So, and NSAIDs might be the commonest caused worldwide for increased liver enzymes as well. So we have to be wary of liver side effects, cardiac side effects, and so there's no proper duration for prescribing. I think those are questions that have been posted here. I think I have
Capsicum.
covered.
Sorry, sir. Capsicum is
Capsicum.
available in Sri Lanka.
Yes, there are certain preparations in Sri Lanka, ointments which have a small amount of capsicum. Actually, we nearly uh, um, tried to do a trial, but we couldn't do it because of COVID. When I was in Anuradhapura, we tried to apply green chili paste just to see whether it works as well as methyl salicylate. But we couldn't try that properly. So it just prevents the brain from concentrating into the joint. It just concern brain. We are tricking the brain into believing that the pain, burning pain, or the severe pain that's coming from the skin is worse than the pain that's come from within the. So it's not a curing method. It just tricks the brain into believing something else.
Thank you, sir.
Right. So there's a final question. I think patients with CKD, what are so CKD? So this is a tricky question. So non-pharmacological, all the methods should be tried before going on to pharmacological things in CKD. There's no best drug in CKD because NSAIDs are contraindicated, and so um, so like even Solindac is not safe, right? So
in the absence of questions, I would like to thank you on behalf of the college, Dr. Himantha Atukorale, consultant rheumatologist, for that very informative and very comprehensive lecture, and at the same time we have a token of appreciation for you, sir.
Thank you. Thank you very much. Thank you for the token. I'm really grateful for the invitation, and I think that this is might have been a useful lecture. And in future also, if time permits, I will definitely contribute to some of as a resource person for some of your lectures. Thank you very much. Thanks.
Thank you, Himantha.
Thank you, sir.
Thank
Good
you,
night.
sir, and good night.